I'm pleased to introduce to you Evan Zahniser. He's a clinical neuropsychologist at the Seattle division of the VA Puget Sound healthcare system. In addition to providing generalist neuropsychological services for adult patients of any age, Dr. Zahniser specializes in assessment and treatment of older adults with concerns related to cognitive decline and dementia. Other clinical interests include positive neuropsychology and approaches to streamlining neuropsych practice in interdisciplinary medical settings. He's board certified in clinical neuropsychology by the American Board of Professional Psychology. So I think you can see he has some great expertise to share with us today on mild cognitive impairment. Welcome, Dr. Zahniser.
Thank you, Barb. I really appreciate the introduction and the opportunity to present here. I'm excited to be here as part of this Northwest GWEC series. And as everybody has heard, my topic for today is mild cognitive impairment, or MCI, as I will be calling it for short throughout the talk. So to get started, I thought I would just kind of resituate us a little bit in this 4Ms framework that we've all been hearing about every week. And mild cognitive impairment, as it sounds like, has mostly to do with cognition. And so we'll be pretty squarely in this mentation section, but there will also be a little bit of discussion related to some of the other M's as well during the talk today. So goals for today, our learning objectives. I'm planning to cover 3 kind of main areas. First, we'll be talking about the diagnostic criteria for MCI and also discussing some other relevant terminology related to the condition. In the second part of the talk, we will talk about distinguishing MCI from some other related conditions or related phenomena like normal aging, dementia, and some other conditions that can affect cognition. And then in the final part of the talk, which I anticipate will be the longest part, we'll talk about science-based approaches to preventing, diagnosing, and managing MCI. So that's where we're headed. But we'll start with this first aim here. And actually, before we get too far into terminology, I wanted to talk a little bit about history. MCI as a diagnostic entity had been around for a little while, but it became increasingly mainstream through a series of seminal papers that were published by Ronald Peterson and his colleagues out of the Mayo Clinic. And these are headings or headers from a couple of the early papers. The first one was published in Archives of Neurology in 1999, and that was where MCI started to come into our mainstream understanding of the condition. And early on, MCI was conceptualized as being kind of an intermediate stage between normal aging and dementia. In other words, this label of MCI was developed to describe people who have experienced cognitive decline that is greater than what happens in normal aging, but it's not yet crossing the threshold into full-blown dementia. And more specifically, actually, when MCI was first being conceptualized, it was understood as reflecting an intermediate stage between normal aging and Alzheimer's disease in particular. And in fact, MCI was considered to be a precursor to Alzheimer's disease, meaning the thinking was that MCI was part of a kind of progression that would happen over time from normal aging into this intermediate stage, and then eventually into the Alzheimer's disease range, or Alzheimer's disease dementia range, as this graphic kind of reflects. So the initial criteria for MCI, which were published in that 1999 paper I mentioned, were focused on a few things. The criteria were really focused on memory impairment in particular, and the main reason for this is that memory impairment is usually a central component of Alzheimer's disease. That's kind of considered the most common and primary cognitive symptom in typical cases. And the initial criteria were so focused on memory impairment, in fact, that it was specified that other aspects of cognition like language functioning, visual skills, attention, etc., that those things would have to remain normal. So it would only be memory impairment that was happening. And as I mentioned earlier, there was also this focus on the progression from normal aging to MCI to dementia. So MCI was being conceptualized as this intermediate stage that would eventually progress into a dementia syndrome, and specifically into Alzheimer's disease dementia. However, our definition of MCI has progressed and expanded over time quite a bit. And this has been for a couple of main reasons. First, not all cases of MCI look like Alzheimer's disease or progress into Alzheimer's disease. And this has been shown increasingly in research. For example, sometimes memory is not the main cognitive problem, or maybe memory is actually not impacted at all. Maybe there is a case of mild cognitive impairment where it's some other aspect of cognition that is mainly impacted. And then second, there's been this growing recognition that, in fact, not all cases of MCI progress to dementia at all. And studies have shown that some people get worse, it's true, but other folks stay about the same, and some people actually have their cognition improve back into the normal range over time. And we'll talk about this more a little bit later when we're talking about management of this condition and that sort of thing. But these two kind of realizations that have happened over time have shaped a newer understanding of MCI as an entity. And so today, MCI is understood as reflecting any cognitive impairment, not just memory loss, but impacts to any aspect of cognition that is greater than expected for a person's age, but it's not into the range of dementia. So it's a little bit broader in that way than the initial conceptualization was. And so listed, listed on this slide are the current diagnostic criteria for MCI. And so we're going to talk through these in some detail here. The first, criterion number 1, says that there have to be some sort of subjective cognitive concerns. In other words, somebody is worried about the patient's cognitive functioning. In most cases, it's usually the patient, him or herself, who's worried about their cognition, but not always. Sometimes it might be a family member or loved one, or it might be one of their healthcare providers who has some concern about their cognition. The second criterion is there has to be some sort of objective cognitive impairment that is measurable. We have to be able to actually detect cognitive dysfunction. And the cognitive decline that we detect has to be greater than is expected for the person's age. And very importantly, this cognitive impairment has to be demonstrated by objective cognitive testing. We have to actually be able to measure this and show it in an objective way. The third criterion says that the person has preserved independence in their functional abilities. And in MCI, this means that they might have some kind of minor changes in their instrumental activities of daily living, which are things like managing medications, keeping track of finances, preparing meals, driving, things like that. But generally, they're still functioning independently in those areas. And this is in contrast to basic activities of daily living, things like dressing, bathing, grooming oneself, that sort of thing. All of the basic ADLs remain fully intact. And so when you think about the sorts of minor changes in instrumental activities of daily living that a person might experience with MCI, you might think, for example, of someone who tells you that it's harder to remember their medications now than it used to be. And in fact, their spouse is now occasionally reminding them to fill their pill box or to take their medications. But in general, they still recall most of the time, and they're able to do the pill box filling and organizing effectively. And more broadly speaking, people with MCI may notice that it takes more effort, or they have to implement more compensatory strategies in order to function, but in general, they are still functioning independently pretty effectively. And then the fourth criterion says that the patient does not meet criteria for dementia. So dementia is a rule out for MCI, and we'll be talking more about this a little bit later when we talk about distinguishing between MCI and dementia. For now, just know that this is part of the criteria for MCI as they're currently laid out. And then we can actually get a little more specific as well. When we identify that a patient has MCI, we can also subcategorize their condition in a couple of different ways. First, there's this subcategorization of MCI based on whether memory impairment is part of the picture for the patient. So if it is, we call it an amnestic MCI. And if there's not memory impairment that's part of what's going on for them, then we call that a non-amnestic MCI. And then there's this second subcategorization we can do based on how many domains of cognition are impacted. So if there's only one aspect of cognition, maybe it's memory, maybe it's something else that is impaired in their condition, we would call it a single domain MCI. Whereas if there are multiple aspects of cognition, for example, maybe it's memory and language, or who knows, if there are multiple domains involved, we call it a multi-domain MCI. And there's this kind of diagnostic subtyping flowchart that the Peterson papers over the years have presented that can assist with this kind of breaking down of the condition. So if we follow the flowchart from the top, you see the diagnostic criteria for MCI are laid out. And then assuming that we have diagnosed a case of MCI, we would ask, is memory impaired? And if yes, it's an amnestic MCI. If no, it's non-amnestic. And then how many domains of cognition are involved? And so we end up with 4 different options. An amnestic MCI that affects a single domain. This means that there's impairment in memory and everything else is normal. Amnestic MCI with multiple domains means that there is impairment in memory and at least one other area of cognition is impacted. And then on the other side of the tree, a non-amnestic MCI that affects a single domain. This means that there is impairment in one aspect of cognition, but it's not memory, and everything else is normal. And then a non-amnestic MCI that affects multiple domains. This means there are impairments in multiple aspects of cognition, but again, none of them is memory, it's something else. And then just a little bit more terminology here. I think this is something that's particularly important when talking with patients about the MCI diagnosis, because there's often some confusion here. So it's very important to recognize that MCI is what we would call a syndrome, as opposed to a specific disease. And as I imagine everybody on this call knows, we use the word syndrome to refer to a group of signs and symptoms that are known to cluster together or co-occur that people experience in conjunction. When I talk about this with patients, I will often say this is kind of like a label that describes their situation or it describes what they're experiencing. In contrast, MCI is not a specific disease. So when we diagnose MCI, there's no explicit mention of the underlying cause, the pathogenesis, the natural history of any disease in particular. It's really just this syndrome label that we're giving. And so an MCI diagnosis leaves open the question of what has caused their symptoms. It doesn't answer that question. It just says what the situation is, but it doesn't say why. And this question of what has caused the patient's symptoms is important for several reasons. So that's an additional step that's also involved. And we'll talk about this further as we go along here. Okay, after a quick water break for me, we can move on to our second learning objective here. So I want to talk a little bit about distinguishing MCI from some other things that can be involved in cognition, including dementia and some other things. So let's talk first about MCI versus normal aging. And I've got the diagnostic criteria for MCI listed here again. And when we're distinguishing MCI from normal aging, we're really focusing mainly on this criterion 2, where there is some sort of objective cognitive impairment that is greater than expected for a person's age. So that's the main focus point here. And to get a little context for this, I want to start with this idea that cognitive concerns are super common. So recognize that cognitive complaints are reported by about a third of people in the general population, irrespective of age. And there have been a number of community-based studies that have dated back to the 1980s, the 1990s, showing really a high frequency of self-reported cognitive concerns in the general population, irrespective of people's age. So there was one study where about 30% of young adults and 34% of middle-aged adults identified as forgetful in a community-based study. Excuse me. All the way to Another study showing about 33% of older adults reporting memory concerns. And here on the screen, I've got this graphic that says, excuse me, excuse me, just one sec. Okay, excuse me, pardon me, folks. Sorry, there, I had something in my throat. So moving on a little bit. So I want to talk a little bit about what happens in normal cognitive aging. So something that's important to recognize is that the brain changes as we age. Excuse me. There's an element of cerebral volume loss that occurs naturally, even in a totally healthy aging brain. And I had a supervisor in my training who liked to say, we shrink, and so do our brains. And it's true. Cerebral volume loss does occur, even if the brain is totally healthy. And changes to cognitive functioning co-occur with this in normal aging. The most commonly reported cognitive concerns among older people are things related to short-term memory, but also problems with word finding and other things of that nature. And here's a bit of a messy graphic. This is from the Seattle longitudinal study where subjects were tracked over their lifespan and their cognitive functioning was assessed repeatedly. And this graphic does show that there are some areas of decline that we experience. For example, you'll see the green dots there that reflect mental processing speed. And unfortunately, this decline does start to occur even in our 20s and 30s. With gradual decline over the lifespan, even in normal aging. And then some other aspects of cognition, like numeric abilities, verbal memory. There is a decline that happens in these areas too, but it starts a little bit later in our 50s or in our 60s. And there's a bit of a gradual decline over time with those things. But it's actually not all decline that we experience. So as you see on the left side of the screen here, there are some domains like processing speed, memory, things like that we've been talking about that do decline a little bit with age. But there are also some brain functions like vocabulary, for example, that in a healthy aging brain continue to get stronger pretty much across the lifespan. And so all of this is to say that our brain functioning really differs depending on our stage of life and our age. And that's important to keep in mind when working with older adults. So bringing it back to MCI, when we diagnose MCI, this requires identifying cognitive decline that is greater than expected for the person's age. And in order to do this, we need to be able to compare the patient's cognitive performance to other people of their age, or what we would call age-matched normative data. And the typical approach here is if we identify cognitive impairment or cognitive performance that falls 1 standard deviation or most commonly 1.5 standard deviations below average for their age group, we would say that that reflects cognitive impairment greater than expected for age. And so that's this criterion number 2 here on the MCI diagnostic criteria list. And notice criterion number 1, subjective cognitive concerns. This is really common in normal aging too, because subjective cognitive concerns are common among older people and across the population age ranges, as we talked about. And so it's really the presence of measurable cognitive impairment that is greater than the decline that can occur with age that distinguishes MCI from normal aging. And again, this has to be demonstrated through objective cognitive testing because self-reported cognitive concerns are not not enough because these are so common. Excuse me. Okay, now let's transition to talking about MCI versus dementia. And for differentiating between these two conditions, we focus more on the latter part of the MCI diagnostic criteria. So it's really criterion number 4 or criterion number 3, and then of course criterion number 4 that we're most focused on here. So MCI and dementia have a lot in common. They're both conditions that involve cognitive decline that is greater than expected for the subject's age or for the patient's age, and that is demonstrated through objective cognitive testing. But the main difference here, remember that in MCI, a person's cognitive functioning remains, or excuse me, their independent functioning remains pretty much intact. They may have some mild changes to instrumental ADLs, but generally they're still functioning independently. Versus in dementia, a person's independent functioning is significantly disrupted by their cognitive impairments. So there might be like really severe disruptions to their instrumental activities of daily living. Maybe they can't track their medications independently at all anymore, or they can't use the stove safely to prepare meals. And then cognitive dysfunction may also impact basic activities of daily living. Imagine the person who requires help getting dressed, or they need reminders to perform basic hygiene, or other things like that. And so this level of disruption to independent functioning, that's really the main distinguishing factor between MCI and dementia. And in order to determine this, we have to have a thorough assessment of their independent functional abilities. If we say they're generally intact, that's likely MCI, versus if they're significantly disrupted, then we're probably looking at a dementia diagnosis. And notice here that cognitive test data are not sufficient. We need to have this information about daily independent functional abilities as well. And this really depends heavily on the clinician to do an interview with patient and ideally with some collateral source of information as well, maybe a family member or a caregiver, in order to get this information about their daily functioning. And so again, the key difference between MCI and dementia, it's really related to this criterion 3. The subject or the patient retains their independence and their functional abilities. And therefore, they don't meet criteria for dementia. So you'll notice that this criterion 4 is really redundant. It's really this criterion 3 that is the key differentiating factor there. Okay, and the last one in this section, let's talk a little bit about MCI versus depression, because this is another condition that's pretty common among our older patients. There have been studies that have shown that as many as 10% of adults 65 and over in primary care settings may have clinically significant depression. And these rates can actually be even higher in mental health settings and other places where older patients are seen. And this is really relevant because cognitive concerns, especially problems related to concentration and to memory, are a known symptom of depression. And especially among older people, this may actually be the main thing that they're reporting, maybe their primary reported concern related to their, mood and that sort of thing that they're experiencing. However, depression is also characterized by other symptoms that may not necessarily be related to MCI, things like low mood, loss of pleasure or enjoyment, which we call anhedonia, losing interest in stuff they used to like, having low energy levels, which can often mean that they're just doing a lot less stuff, problems with sleep, either sleeping too little or sleeping too much, feelings of guilt or maybe a sense that they're being punished, and other things. So a bunch of symptoms that tend to be more specific to depression and not necessarily associated with MCI. But do note that some of these, like apathy, for example, which can look quite similar or maybe be the same thing as reduced interest in stuff that the patient used to be into, this can also be associated with the neurological effects of cognitive disorders. So there is some overlap there. And indeed, These conditions are not mutually exclusive. Depression in general can result from neurological changes, perhaps the same neurological changes that also cause a case of MCI. And for this reason, cognitive decline and mood changes, such as depression, frequently do co-occur. At the same time, MCI and depression can look pretty different from one another upon a formal workup or evaluation. Consider, for example, I imagine many of us have had the experience of we're conducting an interview with a patient and they provide a long, detailed list of all the different episodes of forgetfulness that they experience. Basically, they remember a lot of information about all the stuff they forget. And this is an example of a way a person who has depression and concerns about their memory might present, where there's this kind of juxtaposition between their reported concerns and then what they demonstrate they're capable of doing. Also on cognitive testing, in depression, attention and mental speed problems are often kind of at the forefront, and memory can be much more variable, which is different from MCI. And then importantly, a person who has depression and related cognitive concerns, often if their depression is treated effectively through psychotherapy, medications, or both, their cognitive concerns may get better. And this is also quite distinct from MCI, where that would not be expected to happen. Okay, we're making good progress here. So we've covered our first two learning objectives, and we're going to move on to the third part here, where we talk about actually making the MCI diagnosis, we talk about MCI prevention, and then we also talk about managing this condition. And I meant to mention at the start, we'll wrap things up with a case example to kind of bring this all together as well. So that will finish this section here. Okay. So the recommendations in the literature for making an MCI diagnosis basically say that the clinical evaluation should follow this flow chart that we talked about earlier. And so the first step is to identify the presence of the 4 key MCI diagnostic symptoms, or the diagnostic criteria that we talked about earlier. And then once that is complete and we've identified that this is indeed a case of MCI, then we can proceed to the subtyping that we were talking about earlier. So I'm going to go into some detail about collecting the information that we need in order to make this diagnosis based on the criteria that we have. So the first criterion, the subjective cognitive concerns. The way we typically get this information is through clinical interview, and we obtain clinical history from the patient and hopefully a collateral source of information as well, like a loved one or caregiver, someone who can also comment reliably on the patient's cognitive functioning and any concerns that may be present. And a good thing to note is that MCI is not a condition that reflects a lifelong low level of cognitive functioning. There has to be concern about some sort of change in the person's cognitive status in order to meet this criterion. So if I'm in an interview with a patient, here's some examples of some of the things I might ask them. And a kind of general word of advice here is that open-ended questions tend to be more effective for eliciting information about cognitive concerns. And a main reason for that is that there's a big risk of people over-reporting when they're asked something direct about a specific symptom. For example, if you ask a person, do you sometimes forget conversations that you have with other people? I think probably most of us here on this call would say, yeah, sometimes. I know I forget conversations I have with people occasionally. Whereas if you ask a general question like what's listed on the slide here, have you noticed any changes in your memory or other thinking skills? This is more likely to elicit from the patient what it is they're concerned about, rather than just having them agree with whatever it is you might ask them about. So if I'm interviewing a patient and I'm asking them about cognition, I'll start with a general question like that. I might follow up by asking, has anyone else noticed or commented on these changes that you're describing? And then to gather more information, I'll ask about the onset of their symptoms, like when did you first notice these changes? Or I might ask, how long has this been going on for you? I'll ask about whether there felt like there was a trigger. Was there anything going on at that time that felt like it triggered the changes in your memory or whatever it is they're worried about? And I might also say, or alternatively, did it feel like these changes just kind of showed up gradually over time? And then I'll also want to ask about the course of their concerns. I'll ask, how do you feel like these changes have fared over time? And if I need to clarify or specify what I'm asking about, I'll say, have these changes been getting worse, been getting better? Maybe have they been staying about the same for you? That sort of thing. Okay, moving on to criterion 2, identifying the presence of objective and measurable cognitive impairment. The first step here is often a pretty basic mental status exam where we might do kind of informal memory, language, orientation testing, that sort of thing. And this may also include brief cognitive screening tests or a brief cognitive screening test, such as the ones that are listed here on the screen. And we're going to take a brief sidebar here to talk about brief cognitive tests because this is a subject where I see a lot of misinformation out there and some confusion sometimes, and so I think it's important to touch on. So brief cognitive tests, some commonly used examples are things like the Montreal Cognitive Assessment, the MoCA, the St. Louis University Mental Status Exam, or the SLUMS, and then there's also the Mini Mental State Examination, the MMSE, and several others, but these are some of the most common ones. These brief cognitive tests are tools that were designed to provide kind of a broad characterization, a general understanding, if you will, of a patient's overall cognitive functioning. And I encourage people to think about these as screening measures. They provide a general idea about a person's cognitive status, like I said. And they can indicate when there's concern for a cognitive problem. And these type of tests usually have a cutoff score, meaning that if someone scores below a certain point on the test, there is concern that there may be cognitive dysfunction present. And these brief cognitive tests are great in a lot of ways. They have several strengths. First, they're quick. They're really easy to administer. They're standardized, meaning you follow a manual for the administration. And so ideally, any administration of, say, the MoCA should look the same, no matter who is administering it and no matter to which patient. So it's really this standardized test. Similarly, they're objective, which means that the scoring follows specific instructions. And so scores should be comparable across people, across over time intervals, that sort of thing, based on this objective scoring. And there's a lot of research to show that these cognitive screening tests or brief cognitive tests really do provide meaningful information about cognition. So they're super useful tools. Another strength is that some of these cognitive screeners have multiple forms, which means that we can compare over time with reduced concern about practice effects because people are seeing different versions of the same test. So let's say I give the MoCA to someone and we want to follow up a month later. If we use a different version, there's reduced concern about practice effects there. Excuse me. Importantly, at the same time, our brief cognitive tests also have some key limitations that it's good to be aware of. One of these is that brief cognitive tests are not always as sensitive as we might like. This means that they sometimes miss a cognitive disorder even when it's present. So in other words, the test tells us that the patient is fine, but in reality, there actually is a cognitive impairment there that we're missing. And this is especially common in our really high functioning patients, maybe people who have had a lot of education or for whatever reason, they just have very strong baseline abilities. We're more likely to miss cognitive impairments in that population. And then at the same time, cognitive screening tests or brief cognitive tests also don't have great specificity. And this means that they have pretty high rates of false positives. And this is what happens when the test tells us that the patient has a problem, but in reality, their cognition is actually normal for them. And this is especially common in patients who have lower baseline cognitive functioning, maybe somebody who had pretty limited opportunities for formal education. And it's also especially common in our oldest old patients, especially those ages 75 and up, which is, a big swath of who we're talking about today. Part of the reason for this poor specificity is that brief cognitive tests tend to use a one-size-fits-all approach, meaning they use pretty much the same cutoff score for everybody, regardless of who they are, their age. But as we know, cognition does change with age, and it's affected by other demographic variables like education. And this one-size-fits-all approach, again, can be especially problematic for our older adult subjects. Brief cognitive tests also, they do provide meaningful information about cognition, but they have limited sampling of specific domains. So they won't tell you a whole lot about, say, memory specifically, or language abilities, or executive functioning, or you name it. And there's also research to show that these measures are potentially biased, or at least that they do perform differently for different patient populations. For example, there was a recent study with over 4,700 patients in the National Alzheimer's Coordinating Center. And in this data set, there was a brief cognitive test that was used, and results showed that this test correctly identified 73% of cognitively normal white patients, but the rate was only 41% correct for Black patients. And so there was this major health disparity related to use of this brief cognitive test. And our brief cognitive tests also just have these inherent cultural and language confounds or aspects of the test that involve contents requiring cultural knowledge of the US or at least Western culture, and also familiarity with English. And so brief cognitive tests are not as informative, and they're a lot more limited when we're working with patients who are not as acculturated to Western culture or who may not be as proficient in English. Our brief cognitive tests are just not as helpful with those patients. So when thinking about how to apply these tests, a good rule of thumb or a good thing to remember is that a low score on a cognitive screening test can happen for a lot of different reasons. It might be because of cognitive dysfunction, which is what we're looking for with these tests, but remember that it could also be because of older age. It could be because of lower educational attainment or English as a second language status or other cultural factors or any number of things. And so for this reason, our cognitive screening measures are not intended to be diagnostic. And this is probably the biggest thing to remember about brief cognitive tests, is that they are not sufficient to diagnose MCI or any cognitive disorder. And that's really not what they're intended for. A low score on a brief cognitive test does raise concern for cognitive dysfunction, and usually this indicates that more evaluation is needed in order to make a diagnosis. So let's talk about that. The initial step in identifying objective cognitive impairment often may be brief mental status exam with a cognitive screening test. And then the next step is often what's considered the gold standard for identifying measurable cognitive impairment, which is formal neuropsychological testing. And a neuropsychological evaluation provides a lot of good information. It's a detailed evaluation of a patient's cognitive status and their psychological status. It measures a wide range of different aspects of cognition, such as those listed here. It also compares a patient's cognitive functioning against an appropriate normative standard, specifically matched for their age group, and also for things like education and other relevant demographic variables that can affect cognition. And a neuropsychological evaluation will identify specific cognitive domains that are impacted and areas that are still functioning well. And so all of this information can really guide us when we're identifying the objective cognitive impairment that's part of an MCI diagnosis. And so on this next slide here, I have a graphic that it's kind of a simplification of the results that might come out of a neuropsychological evaluation. So on the x-axis of this graph here, we've got domains of cognitive and psychological functioning. And then the y-axis is the degree to which these domains are impaired. So in this hypothetical example, going from the left, you'll see that mood is pretty close to normal, maybe a little disrupted. Attention functioning is just about normal. This patient's language abilities are mildly impaired. Their spatial skills are pretty normal. There's a moderate range impairment in memory. Executive abilities are, pretty close to normal, maybe a little mild impairment there. And then activities of daily living are close to normal as well, maybe a very mild disruption here or there. So this is, like I said, a kind of simplification of the type of information that we might pull out of a neuropsychological evaluation in order to identify the objective cognitive impairments that are present in MCI. And then last but not least, we also need to identify criteria 3 and 4, which kind of go hand in hand like we talked about. And the main information that we're looking for here is that the patient, even though they have objective cognitive changes, they're still generally functioning independently in terms of their ADLs. And the main way that we get this information, again, is through the clinical interview, talking with the patient, and very importantly, with a collateral source of information as well. And one reason why the collateral is so important is that patients with cognitive dysfunction may not always have insight into their day-to-day functioning and how things are going for them. And so they might not realize some functional changes that they've had. And so we need somebody who has real information about how the patient is doing in their day-to-day life, who can tell us about that. So it might be a family member, another loved one, a caregiver, etc. So in the interview, when I'm asking a patient specifically about their daily functioning, I might transition from asking about cognitive changes to asking about how the changes in the person's memory or whatever it is, how these changes have affected their day-to-day activities, if they have at all. And I might here provide specific examples of day-to-day things that can be affected. I might ask them about managing medications. I might ask them about managing their finances. Driving, shopping, meal preparation, using technology. In fact, I often find that that's a big one with older patients, that one instrumental activity of daily living that can be especially challenging sometimes can be using their cell phone. And so that's something I will ask about specifically as needed. And here, if needed, it can be more helpful to ask pretty specific questions. For example, I might ask someone, have there been any times where you have forgotten to take your medications, or maybe times where you got mixed up about what you needed to take when, something like that? Are there times where you've forgotten to pay a bill, or maybe you got mixed up and paid twice by accident? Have you had any motor vehicle accidents or any near misses, or have there been times where you've been pulled over or maybe even gotten a ticket? Things like this to elicit specific examples of ways that day-to-day independent functioning could be impacted by cognitive changes. And again, as I mentioned, it's really important to have a collateral source of information here, because they may know more or they may have more insight into these sorts of changes that the patient may be lacking. Okay, so let's say we have elicited all of this information, we're confident in an MCI diagnosis. The next step is to consider subtypes. So let's think about an example patient here, someone who meets criteria for MCI. There's memory impairment involved, and language is also impacted. So as we go down this kind of decision tree flow chart here, we would identify this as what we would call an amnestic multi-domain MCI, because remember, memory impairment is part of the picture, but it's not the only impairment. Language is also involved. So that would be an example of this kind of subtyping that we would do. Very importantly, along the way when we're diagnosing MCI, there are a few other things that we want to be thinking about. And I think some of these things can be especially relevant in a primary care setting where, a lot of other reversible causes of cognitive dysfunction, for example, will want to be ruled out. So we'll want to consider things like vitamin deficiency or endocrine dysfunction, or maybe an infection, or maybe some other medical condition like diabetes or sleep apnea that's not being managed optimally, or maybe there's some kind of medication-related effect going on that's affecting cognition. We want to consider all of these things that could be reversed in order to rule this stuff out when making an MCI diagnosis. We might also consider whether neuroimaging would be helpful. For example, if there's concern about like a tumor or a stroke or some other focal neurologic change affecting the brain, we would want to consider whether neuroimaging could help to rule some of this stuff out along the way as we're making this diagnosis. But let's say that we've ruled out these reversible causes. At this stage, we have an MCI diagnosis, and maybe we've even identified a subtype of MCI like we talked about before. So the next question would be, is it possible to think about what's the cause of this case of MCI? Consider etiology, in other words. And when we're doing this, we would want to think about common causes of cognitive impairment among older adults. Some examples are Alzheimer's disease, cerebrovascular changes, the pathology that causes Lewy body disease and Parkinson's disease. We might consider frontotemporal lobar degeneration, and we might consider other medical conditions or external factors that can affect the central nervous system, things like kidney disease, cancer, HIV. Maybe there is a history of substance use that has affected the brain, those sorts of things. And note here that the determination of what's the probable etiology in a case of MCI is super complex. It's based on integrating their information about their symptoms, the course of their condition, their medical history and other histories, cognitive test data that we've collected, and other streams of information as well. And recognize that there may be a mix of multiple factors that contribute to cognitive changes. And as a result, a conclusive determination of the cause is not always possible. That being said, useful information, for example, that comes from a neuropsychological evaluation can sometimes help. There are certain profiles of cognitive impairment that are more commonly associated with specific diseases. For example, we talked earlier about memory loss being a hallmark feature of Alzheimer's disease specifically. And when we can identify an etiology, this does help to clarify the diagnosis. And it also informs our understanding of prognosis and guides our treatment and management of the condition. So when possible, we want to try to attempt to specify what we think the cause is, if we can. All right, so let's talk a little bit now about prognosis and management of MCI. And then the last part we'll get into here is prevention in the next few slides. So although MCI is considered an intermediate stage, like we talked about, not all cases of MCI get worse. What we call the conversion rate, meaning where MCI worsens into the dementia range, the conversion rate is about 10% of MCI cases per year then move or worsen into the dementia stage. But some cases stay the same. Some cases of MCI, the level of cognitive dysfunction remains stable. And actually, some cases of MCI get better, meaning that their cognitive functioning moves back into the normal range over time. Importantly, or it's important to recognize that there are no medication treatments for MCI that are currently approved by the FDA. So the treatment that we focus on for MCI, it really emphasizes things like lifestyle management, health behavior interventions, and general things in that category. So to manage a case of MCI, we will focus with the patient on optimizing their medical health, especially their cerebrovascular and cardiovascular risk factors, things like high blood pressure and heart disease. We'll really focus on increasing adherence to other medical treatments, like if they have a CPAP for sleep apnea or hearing aids. We'll want to consolidate medications in order to reduce anticholinergic burden as much as possible. And then we'll also encourage lifestyle modifications or just good brain healthy lifestyle habits, things like good physical activity levels, a balanced diet, adequate restful sleep, staying involved in the hobbies that they like and the social connections that are good for them. We'll focus on substance use, so encouraging moderate or less alcohol consumption, encouraging people to quit smoking if they smoke cigarettes. If a person's mental health is suffering, we'll want to connect them with mental health services. And then also, in order to help a person maintain their independent functioning, we'll want to consider compensatory strategies that could help them to continue to function at a high level despite the changes in their cognition that they've experienced. So these are all the different areas that we'll focus on to try to manage a case of MCI once the diagnosis is made. And now let's talk a little bit about prevention. And you'll notice that a lot of the same things listed here are the same, or a lot of the things listed here rather, are the same things that we do to manage MCI. So starting these habits early is better. It doesn't have to wait until a person is diagnosed with MCI. A lot of the same stuff that helps to manage the condition can also help to prevent it. I think it's worth noting that a lot of the prevention research has focused on dementia, but the findings, I think, generalize to cognitive decline in general. And research has consistently shown that there are a number of lifestyle habits that are associated with cognitive benefits in older people. And they're listed here. Things like physical activity, staying socially engaged, staying mentally engaged as well. A Mediterranean diet is especially related to better cognitive functioning among older people. Getting enough sleep, keeping cardiovascular risk in check, avoiding tobacco, keeping alcohol use at a moderate level or lower. And then a couple things that I think are worth noting. There's research showing that maintaining a sense of purpose in one's life is related to cognitive benefits in older adults. And the same is true of having positive attitudes about aging. So these are things we want to promote in our patients as much as possible. There was this really cool kind of landmark study that came out in 2020, published by the Lancet Commission on Dementia Prevention, Intervention, and Care. And the citation is listed here in case you want to read it for yourself. But the main takeaway message from this publication was this idea that about 40%, which is a huge number, about 40% of dementia cases worldwide are accounted for by these 12 modifiable risk factors that are listed here. So these include having less education, having high blood pressure, having hearing impairment, using cigarettes, having obesity, having depression, low physical activity or physical inactivity as they call it, having diabetes, having low social contact, using alcohol excessively, having a traumatic brain injury, and then air pollution. And notice that several of the factors on this list are distributed unequally. For example, access to education is not the same for everyone. And there are major health disparities related to conditions like diabetes, obesity, and others. And air pollution is another one that affects certain populations or certain regions much more than others. And so the risk of cognitive decline that's associated with these modifiable factors, it does disproportionately impact several disadvantaged groups. And the reasons for this are distinct in some ways, but overlapping in others. And I think the big takeaway idea here is that up to 40% of cases of dementia could be prevented if we could account for all these factors. And so the authors of this study focus on several specific steps that can be used to reduce the risk of cognitive decline. And as I mentioned, the paper is focused on dementia, but it's the same idea for preventing MCI. These are specific steps that can be taken to reduce risk of any sort of cognitive decline. One of them is maintaining a healthy blood pressure, and the authors go out of their way to state that blood pressure medications are the only medication we know of that actually prevent dementia and other cognitive disorders. Encouraging use of hearing aids, since hearing loss is a risk factor for cognitive decline. Reducing exposure to air pollution, preventing head injury, limiting alcohol use, avoiding smoking or supporting people to quit if they are smoking. Sustaining physical activity in midlife and late life, preventing and managing diabetes. These are all listed as specific steps that can help to prevent cognitive disorders like dementia and like MCI. And I think it's also really important to note the authors focus on this idea that preventing cognitive disorders, it does require these individually focused steps. but it also requires public health initiatives and kind of bigger picture changes. For example, the authors highlight the immense benefit that universal primary and secondary education could have on reducing rates of cognitive disorders in older people. They also emphasize the importance of targeting health disparities. In the US, many of the risk factors that are talked about in this publication cluster in our Black populations, our Asian populations, and other minority racial ethnic groups and other vulnerable groups. And so reducing and eliminating these health disparities is one really impactful way to reduce the overall rates of cognitive disorders. And they also emphasize from a more global perspective that while cognitive disorders in general are happening less often in higher income countries, the same is not true in lower and middle income countries. And so there are these ongoing disparities that we can really focus on here to try to prevent MCI and cognitive disorders in general. Excuse me. Okay, so to kind of wrap things up and bring everything together here, I thought we would talk through a case example. And this is intended to represent a fairly typical presentation of a patient who might be seen in a primary care setting, and then the steps that might be taken next based on their concerns and that sort of thing. So imagine that you meet this patient. They're a 66-year-old man, a retired high school teacher, and they come to see their primary care provider, and they're reporting concerns that they're more forgetful over the past year or two. They tell you that they forget details of conversations. They sometimes forget about plans they've made or appointments they have, and sometimes they misplace their important items as well. There have been a couple instances where they forgot to take their medication for high blood pressure, but they remember most of the time, and the patient's spouse has been reminding him more in recent months to take his medications. And he's using a pill box, which is working pretty well for him overall. He's also driving without any issue, and he continues to be the person who's mainly in charge of managing finances for his household, and that's going fine. He doesn't have any major concerns related to his mood, to his sleep, to pain levels, or any sort of substance use related problems. He does have a medical history that's notable for high blood pressure, and he has mild hearing loss, but otherwise his medical history is pretty unremarkable. He takes a medication for his blood pressure, and he also has a daily multivitamin, and that's it as far as medications. And he does share that he has a family history of dementia. His mom was diagnosed with probable Alzheimer's disease when she was in her early 80s. And so this makes him a little more worried because he's seen family members who have had dementia. And so he worries about his own cognitive functioning. So I guess just as a comment here, this is a common presentation that clinicians will see among our aging patient population. This is somebody who's noticing they're more forgetful, and they're worried that this might reflect something more than just normal aging. He has a pretty unremarkable medical history. There are no obvious comorbidities or medication side effects that might be expected to be causing his memory problems. And so at this point, a mental status exam is indicated as a good next step in assessing his concerns. So an in-clinic mental status examination is performed, and it's pretty unremarkable. Things like sensory motor function, language, his thought process, his mood, his affect, this stuff is all pretty much within normal limits. But there is a little bit of informal memory testing that happens, and it's concerning for a little bit of mild forgetfulness. So specifically, the patient is fully oriented to person, place, time, situation. He remembers who our president is and who the most recent past US president was. However, he can't remember what he had for dinner last night, and he only remembers 3 out of 5 words that he was initially told following a short delay with a distractor task. And so following this, there's some cognitive screening that's completed using the MoCA, and he scores 23 out of 30 here. And this does fall below the cutoff. The typical cutoff on the MoCA is 26 out of 30. And so his score falls below this cutoff, and this raises concern that he might be having some sort of cognitive dysfunction and that more workup would be appropriate here. So he is referred for neuroimaging, and he has a brain MRI, and results show some mild volume loss that's considered to be within normal limits for his age, because remember, our brain volumes do change as we get older. And there's also the presence of some mild cerebrovascular changes, kind of microvascular white matter ischemic disease that's scattered throughout his brain, especially affecting the subcortical and periventricular white matter. He has a lab workup, a bunch of blood work done, and his things like TSH, vitamin B12, syphilis, and HIV screen. He also has a metabolic panel and blood count, and this stuff's all normal. And then he's sent for a neuropsychological evaluation to perform more detailed testing of cognitive function in particular. And results from the neuropsychological evaluation show that his cognition is mostly normal for his age and educational background. But the exception to this is his memory. And his testing displays mild impairments for recall of things like lists, paragraphs, and nonverbal content. So kind of global memory problems, we might say. So let's think about this case and consider the diagnostic criteria for MCI. The first criterion, subjective cognitive concerns, certainly present. This patient is worried about their cognition, and he's worried that he's experiencing a change. He's more forgetful than he used to be, and worried that this might reflect a problem that's greater than just normal aging. Based on the results of neuropsychological evaluation, we can conclude that criterion 2 is also present. There is measurable cognitive impairment present on his testing, and it's greater than what is expected for age, because remember, his performance was compared against his age group specifically. So cognitive testing does show that criterion number 2 is met. And then number 3, preserved independence and functional abilities. Yeah, he's still functioning pretty well. You know, there have been these mild changes in his medication habits. He has forgotten his blood pressure medication a couple times, but now he's using a pill box, and you know, with his spouse's reminders occasionally, he's still taking his medications effectively and managing well in other domains. And so certainly he does not meet criteria for dementia. So based on the information that we have so far, I think we can conclude that we're seeing a case of MCI here. So the next step would be to think a little bit about subtyping. And so assuming that all of these criteria are met as they are, the first question would be, is memory impaired? And yes, it is. That's his main concern. And that was the main area shown on cognitive testing as being impacted. So this is an amnestic MCI. And memory is the only impairment that cognitive testing showed. So specifically, we would call this an amnestic MCI affecting just that single domain of memory. So thinking about the etiology and prognosis associated with this case of MCI, neuropsychology, their opinion is that the etiology is not fully clear. They mentioned that on the one hand, there's the potential that this could reflect vascular cognitive impairment, since his neuroimaging showed that there were some cerebrovascular changes. At the same time, his cognitive profile is concerning for a neurodegenerative etiology, and so they mentioned that this is also possible, but it's not really possible to tell for sure at this stage. And so they recommend that he be sent back for a repeat evaluation in around 12 to 18 months in order to monitor. And the prognosis is uncertain. It's possible that his cognitive decline might progress, but it might also stay stable or even get better. And so this is one reason that they want to have him back in order to keep an eye on things. In the meantime, treatment and management of this case of MCI, as always, we would focus on emphasizing lifestyle changes, health behavior changes, and that sort of thing. For this patient specifically, we would really emphasize the importance of managing his hypertension to reduce cerebrovascular risk, since we know that this is a key risk factor for cognitive decline. We will recall he also has some hearing loss, and so we'll want to encourage him to use his hearing aids on a daily basis. Since memory is really the main problem that this patient is experiencing, we'll want to work with him on compensatory strategies to manage this memory problem. One might be using a pillbox for medications, which is already a habit he has started to implement. We might also encourage him to use a calendar, whether a paper calendar or a virtual one, for his appointments and plans, and to build a routine where he checks this calendar each morning so he knows what he has going on that day, to try to reduce instances where he forgets about appointments and plans like he complains of. We'd also encourage him to write notes to himself of information he wants to remember later, perhaps to program reminders into his cell phone about activities or chores or tasks he needs to complete, and to keep his important items in what we might call a home base, or just keeping those things always in the same place so that he doesn't misplace them. We would also encourage lifestyle habits like staying physically active, eating a balanced, perhaps Mediterranean-based diet, getting enough sleep, and staying involved in the things he likes and hanging out with the people he enjoys hanging out with. And then we would want to re-refer him to neuropsychology in about 12 or 18 months for further monitoring. So with that case example, I will wrap up my slides here and kind of open the floor for questions. I see there are some notifications in the chat, so there may be some questions there. And thanks everyone for your attention. Glad to have had a chance to talk about this.
Yeah, this has been great, Evan. I really appreciate it. I actually particularly appreciated this early slide where you talked about normal aging and then some things that actually can get a little bit enhanced with aging. So that was helpful. We do
Yes,
have some
it's not
questions.
all a negative change that
Yeah.
happened. It's good to remember there are some things where we get better as we get older too.
Well, and it adds to, like what we typically talk about is wisdom, which,
Mm-hmm. Mm-hmm.
it's yeah. Anyway, so uh, when you were talking about cognitive screening, we had a question about your thoughts on cognitive screening for patients that are bilingual or culturally diverse. Do you have a best approach or a test of choice that you might use?
Gosh, that's a great question. There are many versions specifically of the MOCA that have been developed and validated in other languages. Of course, in order to administer it, the person giving the test needs to also speak that language, which I think that tends to be probably the biggest limiting factor. Um, Often with someone whose culture and or language background is quite different from that of their healthcare provider. Let's just consider the example of an immigrant from another country who speaks some English, but it's their second or third or fourth or whatever language, working with a healthcare provider here in the US. The cognitive screeners are just less effective tools in that case often. And so sometimes that's even more of an indication that a comprehensive neuropsychological evaluation could be helpful, because there is sometimes more that can be done there to make meaningful comparisons for cognition. That's a great question. It's a really challenging example.
And then we had a question from Mary Zeitner, and Mary, I've unmuted you so that you can add to this. Mary had posed about weeding out factors such as generally appropriate pain medications, opiates, and the still not controlled pain. How do you deal with that in your work? And Mary, do you want to add a little bit to that context?
Well, the person is my husband, actually, and
Okay.
and he's very frustrated that the pain after all this time still isn't controlled, and so he can't do things that he'd like to be doing, and but he's having bouts of dizziness and what I would call acute forgetfulness, and then that will clear later. Like he won't remember a conversation from maybe an hour ago, and then that all seems to come back and he appears normal. But if there's some, and there's lots of other factors too. Yeah. But are there ways of dealing with trying to find something that works well without causing other problems?
Gosh, yeah, a great question. And that really highlights the complexity of some of these situations. As a neuropsychologist, I don't prescribe medications, and so the medication questions I would always defer to my physician colleagues. But when it comes to the forgetfulness that you're talking about, that's exactly the sort of thing that we would want the patient, in this case your husband, to discuss with his doctors, and he might be referred for a more thorough evaluation to try to understand, what's the cause of this? Is it mainly just related to the pain, or could there be something else going on? And another shameless plug, I guess, for neuropsychological evaluation and how it can help to distinguish among those sorts of things.
He is involved with brain wellness.
Excellent.
So I have a question from Sheila. This is a great question. I love it. What do you mean by positive neuropsychology? Are there
Oh,
positive interventions such as mindfulness and intentional kindness that are evidence-based? Are you thinking of other aspects of positive neuropsychology?
thank you so much for asking that. So I guess just as a broader comment on clinical psychology, which is my field, and neuropsychology, my subfield, I guess, we tend to focus on problems, on what goes wrong, and making diagnoses and treating the problems that happen. Positive neuropsychology is the focus on what goes well with our neuropsychology. What things can we do to function at a high level or to function at our best? And the sorts of things you listed, like mindfulness and that sort of thing, those things are super evidence-based when it comes to psychological health. When it comes to neurocognitive health, it's more of the preventative type stuff that I was talking about in the later slides, like staying physically active in midlife and late life, eating a balanced diet, getting enough sleep. I always talk with my patients about what I call the big three, because these are three of the lifestyle habits that we know that have the most powerful positive effects on brain health. And it's physical activity, mental activity, and social activity. And so I always tell my patients, if you can keep your body moving, if you can focus on the things that are interesting to you, and if you can spend time with the people that you love, those are the things that will go the longest way to keep your brain healthy. And that's positive neuropsychology right there. It's focusing on what we can do to have our brains function well, as opposed to the ways that our brains can break down. And, that can be different sides of the same coin, I think. And it's more of that prevention and enhancing functioning mindset. Thanks for asking that.
And this kind of follows up on that, related to recommendations for prevention of cognitive decline and physical activity in mid and late life. And this person was asking, since for cardiovascular risk factors, we have kind of predictable targets, prescription, that sort of thing. For example, the general exercise intensity for humans recommended by the American Heart Association to prevent CVD is moderate exercise of 30 minutes to 5 times a week. Do you have some more specific recommendations for physical activity related to cognitive decreasing or preventing cognitive decline?
I think actually the good news is that the recommendations are pretty much the same, and the reason for that is that the mechanism is kind of the same. The main, or not the, but a main way in which physical activity has beneficial impacts on the brain is by keeping the heart healthy, because the heart is what supplies the brain with blood oxygen, blood sugar, and the things it needs to function. Whereas when there are problems with the heart, that can have downstream negative consequences on the brain. And so one of the main ways in which physical activity is good for the brain is through that mechanism of being good for the heart. And so it's the same recommendations, that 150 minutes of moderate to strenuous physical activity per week, which equates to about 30 minutes a day, 5 days a week. It's the same type of recommendation that works for both.
Great, thanks.
Mhm.
And Linda is wondering if there's much of a genetic component to MCI, and I guess wondering particularly MCI that might progress to dementia or Alzheimer's.
Yeah. Oh man, another great question. And clearly shows how much information there is out there that I was not able to even fit into the slides. So the short answer is that there can be a genetic component, and it really gets down to what is the underlying cause of a person's MCI, because as we discussed, MCI is a syndrome, it's a description, it's not a specific disease. And there are some specific diseases like Alzheimer's disease that can be associated with genetic factors and can cause MCI. And so some instances of MCI are related to genetics. And to the other part of the question, yes, those cases of MCI tend to have greater risk of progressing or converting to dementia over time if they're associated with those genetic factors.
What about games that help your mental ability, like word finding games and brain teasers, that sort of thing?
Yeah, a good question. Those things fall under that kind of mental activity heading, and the scientific research on brain games, it mostly shows that if you do a lot of brain games, you get better at brain games, but it doesn't necessarily translate to other aspects of brain functioning. And so what I tell my patients who ask about brain games and that sort of thing is that if that's what you enjoy doing, if that's your favorite recreation, then great, by all means, knock yourself out with that sort of thing. But if there are other things that you enjoy more, whether it's learning a musical instrument or learning a language or bird watching, or the list goes on, whatever a person's interests are, whatever they find to be stimulating and interesting to learn about, that's what I encourage them to focus on. It's more important that a person spends time on the mental activities that are fun and enjoyable and stimulating for them than that they do any specific sort of brain game. So I think it's kind of an indirect way of answering the question, but the short answer is that the brain games don't have a lot of scientific research to support them unless it's already a person's area of interest anyway, and then it's great.
Thanks. That's actually a great question and a helpful response that I haven't heard much about. I've been concerned in the past about some of these really expensive computer games that people kind of get engaged with, but once you've been through the sequence, what do? Do you have to buy more? Do you have to upgrade? That sort
Yeah,
of thing. So,
and that can be one of the big downsides to some of these. There are a lot of commercially available brain game products, and also like supplements and stuff that people will read about or see TV commercials for, that say that they're going to make a person's brain function better, or make you age more slowly, or whatever their claims are. And that can be one of the big problems with those things, is they're expensive, and so a person ends up sinking a lot of their money into it, and maybe it doesn't help them much anyway. So I'm always encouraging people to focus on whatever it is that they enjoy most, and to be wary of those products that are going to cost a lot of money.
well, this is a great question. Fallon is asking, can you speak about any research connecting our gut and our brain health? Is the Mediterranean diet does it support that connection?
That's a good question, and that's not an area I know a lot about. Specifically, what the mechanism is that leads to the Mediterranean diet being associated with good cognitive outcomes, I don't know for sure. All I know is that the research shows that there are a lot of, different kind of crash diets out there that are not particularly helpful for brain health, and that the Mediterranean diet and some of its variants, like there's a diet called the MIND diet, that has been kind of discussed more lately, that those diets are the ones that actually have research support to show that they lead to, or at least are associated with, positive outcomes. But I don't know a whole lot about what the specific way in which that happens is.
Any other questions, folks? All right, then I will just say thank you, Dr. Zahniser, for this great talk. We have not had this topic as part of our library before, so this is just a tremendous addition to a comprehensive focus on Alzheimer's disease and related dementias, and mild cognitive impairment, which everyone puzzles about.
Well, thank
I was
you.
I will see everyone again next week, and feel free to fill out the evaluation survey, and we'll hang on for a couple of minutes and then close out the session. Thanks so much, Dr. Zahniser.
Oh yeah, thank you. And I saw all the applause emojis popping up. Thanks everybody for that. Appreciate it.
I can never figure out how to do that. Ah, okay. All right, everyone, have a really nice, wonderful, sunny week and weekend.